relatively short lecture that covers coronary circulation. Before I cover what's in your manual, I want you to understand the significance of understanding the coronary circulation. If blood flow within the heart, within the coronary blood vessels, is insufficient, that can lead to what we call ischemic heart disease. And if you look at these images, these were imaging studies. On the left, you see a heart that's healthy. The blood vessels are nice and open and patent. Blood flow is good. And over here, there are some blockages. And so parts of the heart are getting very little to no blood flow. And when someone says to you ischemic heart disease, ischemia means insufficient blood flow to meet the metabolic demands of a tissue. So if you don't have enough blood, you're not going to get enough oxygen, not enough nutrients, won't be able to get waste products, and the functioning of a particular tissue won't be optimal. Now, ischemic heart disease can result, actually the most common cause of ischemic heart disease is atherosclerosis, blocking of the coronary blood vessels. And so often ischemic heart disease is referred to as coronary artery disease, but ischemic heart disease is not necessary because of blockage of coronary blood vessels. What I want to talk about is the coronary blood vessels themselves and what controls blood flow within the heart. And then obviously you can take it one step further, that if I have a blockage in a blood vessel within the heart won't be able to work as well as it should. The coronary circulation, we can refer to either a right coronary dominant heart, a left coronary dominant heart, and sometimes in about 15% of the population they have what we call codominance. Now, what does it mean by saying right coronary dominant or left coronary dominant? The term comes from which blood vessel gives rise to the posterior descending artery, which you see here, posterior descending artery. If you have a right coronary dominant heart, which is most common, about 80 to 90% of the population have a right coronary dominant heart, that posterior descending artery arises from the right coronary artery, hence the term right dominance. If the posterior descending artery arises from the circumflex branch of the left coronary artery, it's considered to be a left coronary dominant heart. Now, one thing to keep in mind, the left coronary dominant heart, that posterior descending artery, is not arising from the left coronary artery, but rather a branch of it. It's the circumflex branch of the left coronary artery. So this is not as common, which is a good thing, because if you look at the pictures below, if I have a right coronary dominant heart, you see parts of the heart, or in this case parts of the septum, that is getting blood from the left anterior descending artery and the posterior descending artery. And then over here, in the left coronary dominant heart, the entire septum is supplied by branches of the left coronary artery. So if you have a block, or complete block of the left coronary artery, then this is usually a fatal event because you lose all of the septum, which is not a good thing. So this is probably good that most people do not have a left coronary dominant heart. Now, the reason why they refer to the circulation in the heart as a coronary circulation is corona is a term in which refers to as being a crown. These blood vessels of the heart circle the heart kind of like a crown. So you have these kind of superficial arteries, but obviously you'll know that some of the arteries obviously will eventually branch and go deep into the muscle to supply the muscle with blood. Now, if you look at these pictures to depict the coronary blood supply, you'll notice that the right coronary artery here, and in this case, this person is a has a right dominant heart because here's the right coronary artery. You're looking at the heart in the back. It serves the posterior interventricular artery, which is also called the posterior descending artery. Now, the arteries are going to be supplying the heart with oxygenated blood, and each artery in its branch serves particular areas within the heart. They're going to give it nutrients, all that good stuff. The veins will pick up all the relatively deoxygenated part, or the blood, and deliver that blood back into the heart to be able to go up to the lungs and become oxygenated again. Now, in the left ventricle, most of the blood leaves by way of the coronary sinus right here, okay, in about 3/4 of the population. It empties in the coronary artery by way of the cardiac veins. For the right ventricle, that leaves by anterior cardiac veins, which you see over here, anterior cardiac veins to the right atrium. The Phasic veins, which we can't depict here, these pick up some of the blood and actually empty into all chambers of the heart. So you actually get some deoxygenated blood that's going into all chambers of the heart, but most of it eventually is going to empty back into the right atrium. The regulation of coronary blood flows. We got to talk about what's the significance of how we control coronary blood flow. Now, resting coronary blood flow is about 4 to 5% of your total cardiac output. Maybe something like 250 mils of blood per minute is in the heart at one time. It will increase definitely as your metabolic demands go up, say with strenuous exercise, and it can increase up to about 4 to 6 times normal. So what is the main way we regulate blood flow within the coronary circulation? Well, one thing that can influence coronary blood flow is resistance. Well, you know the flow equation. You'll say, well, flow is equal to delta P over R. If I increase resistance, that will decrease flow. And we've always been referring to it as resistance within the muscle, the vascular smooth muscle, constrict or dilate a vessel. And when we look at coronary blood flow intrinsically, when we talk about regulation of the vascular smooth muscle, in the heart, the blood vessels have a lot more beta-2 adrenergic receptors than they do alpha-1. Remember, beta-2 adrenergic receptors will respond to sympathetic stimulation by vasodilating, which is what you would want in the heart when metabolism increases and you're in fight or flight. But one thing, even though we've got some beta-2 adrenergic receptors in the heart, very few alpha-1 on the blood vessels in the heart, there are not a lot of adrenergic receptors on blood vessels in the heart. It is mainly a metabolically controlled circulation. We're going to look at this a little bit more in a moment. Now, extrinsic effects or extrinsic resistance, this has to do with mechanical compression. What we're going to look at, because if you have blood vessels that go down deep into the muscle of the heart, because if the heart contracts, what will happen to resistance of those blood vessels? Are you going to externally compress those vessels and affect flow? Well, if you look at the picture in your notes, you see over here that we're looking at coronary blood flow during the cardiac cycle. You'll notice that in the left ventricle, during systole, there's very little blood flow, but it's okay during diastole. Within the right ventricle, you have blood flow during systole and diastole. So why do you have very little to no blood flow during systole in the left ventricle? Well, it has to come down to external compression of the vessels and comes down to pressure gradients. So if you look at this picture over here, these depict the pressures that you see in the blood vessels. And here, if you look at the right ventricle, the pressures you get within the right ventricle peak during systole about 25 to 30 millimeters of mercury. They drop to 0 during diastole. Well, you'll notice in the blood vessels, coronary blood vessels versus what's in the chamber of the heart, there's always a pressure gradient during systole and diastole. As long as you have a pressure gradient, you will have flow. But if you notice over in the left ventricle, the left ventricular pressures get up to 120 millimeters of mercury. So during systole, you do not have a pressure gradient, so you won't have flow. During diastole, you do, so you will get flow. So big thing to get from this is that in the left ventricle, that during the cardiac cycle, you have what we call phasic or intermittent blood flow. You get blood flow during diastole, but not as much during systole. In the right ventricle, we have continuous flow through the entire cardiac cycle, and this has to be because of the external resistance, mechanical compression. So if I just asked you, where is most likely the cause of myocardial infarctions in the heart because of a result of a lack of blood flow? The answer is going to be it's most likely in the left ventricle because that can get the least amount of blood flow in the cardiac cycle. If you also kind of look at the heart and kind of look at in sections, that you have the endocardium, which is right next to where the blood is, right here. Here's the epicardium. If you look at variations in blood flow for the blood vessels up here versus down here, subendocardial, right underneath the endocardium, there is going to be a difference. You get the least amount of blood flow right here. The reason is the muscle here is the first to contract. And then right on top of it, they'll contract on top. And then out here, they're going to contract and keep compressing down on the blood vessels there in the subendocardium. So the subendocardial blood vessels get the least amount of blood flow during the cardiac cycle. Up in the epicardium, they get the most. So we can take the question I asked you on the previous slide and take it one step further. Where's the most likely cause of ischemia or a heart attack in the heart? It's going to be in the subendocardium of the left ventricle, since it gets the least amount of blood flow. But we do have some adaptations within the heart to try to give it a little more blood than it would if we have it set up the way we just talked about it. There are differences in the makeup of the vessels in the up near the epicardium and down near the endocardium. So in this picture, this top one represents the vessels in the epicardium. This represents the intramuscular arteries that are going down, penetrating within the muscle. Down here represents the vessels within the endocardium or subendocardium. There is arrangement, different arrangement in receptors within the vessels, plus the subendocardial plexus is more extensive than the epicardial. So we try to depict it by having this a little bit wider. So it will help to somewhat compensate for the fact that the subendocardial plexus is always going to have that external compression on it during systole to try to get it a little more blood flow than it normally would. But also, we have a different distribution of receptors, or the adrenergic receptors. The epicardium has a little more alpha-1 than beta-2. The endocardium blood vessels have more beta-2 than alpha-1. So the beta-2, again, respond to sympathetics by dilating. So it helps to, these two things, having a little more extensive network in the subendocardium, slightly different distribution of adrenergic receptors, helps to maintain more flow during the cardiac cycle, specifically during systole. We're not saying you get absolutely no blood flow, but you don't get as much during systole as you would in the right ventricle. Now, the coronary blood flow, the regulation, is primarily intrinsic control. It is control of vascular tone by metabolism, local control of blood flow. It's almost completely regulated by metabolism. One of the most important means by which it does is its demand for oxygen, which is mediated through adenosine. Now, adenosine, remember, is a breakdown product of ATP. So if ATP is completely broken down, you keep removing phosphate after phosphate after phosphate, you're going to left with adenosine. And adenosine is a very potent vascular smooth muscle relaxant, which would cause dilation of the blood vessels to try to get more blood to that muscle. Now, one thing to keep in mind is the cardiac muscle extracts a lot of oxygen from blood first go around. Unlike most other tissues, the cardiac muscle automatically extracts a lot of oxygen already from arterial blood. So the only way that you're going to be able to increase oxygen delivery to the heart is to increase blood flow. Because earlier we had talked about local control of blood flow, and we discussed that there are two means by which you can increase blood flow to a tissue. Oxygen delivery to the tissue. Increase blood flow or abstract more oxygen from the blood. The heart already abstracts more oxygen to begin with, so the only way it's going to be able to get more oxygen is to somehow increase blood flow. So how does it do it? Well, let's look at the nervous system control, the ANS, autonomic nervous system. You have here direct effect of sympathetic input, direct effect of parasympathetic input. So let's explain what this means. You have those adrenergic receptors on coronary blood vessels. The direct effect of sympathetic input would be if it found an alpha-1 adrenergic receptor that would vasoconstrict the vessel. But this isn't a huge thing in the heart because you have very few alpha-1 adrenergic receptors. The beta-2, which we have a little more beta-2 than we have alpha-1, those are going to respond to the sympathetic activity by dilating. But, again, the number of adrenergic receptors that we have on the blood vessels in the heart are very little. We have the parasympathetic input is very slight, if any, because you have almost no innervation of blood vessels by the parasympathetic. So really no effects from direct stimulation. But what you will have is you'll have indirect effects of changes in sympathetic or parasympathetic activity. So you could probably change these to the input here to activity. So what happens if I have increased sympathetic activity within the heart? What is its effects on the blood vessel? So here how it goes down. If you have an increased sympathetic activity in the heart, you're going to increase heart rate, you're going to increase cardiac contractility by way of its effects on the beta-1 adrenergic receptors found in the SA node and in the myocardium, the muscle itself. So an increase in metabolism will result when heart rate goes up and contractility goes up. Therefore, you're going to have increase in metabolic byproducts being produced within the muscle, which will influence the blood vessels, the coronary blood vessels. So if you have an increase in lactic acid production, an increased demand for oxygen, an increased hydrogen ion concentration, higher CO2 levels, those are all potent vasodilators. So the effects of metabolism will cause dilation in the coronary blood vessels. The parasympathetic activity, if you have increased parasympathetic activity, you're in rest or digest mode, heart rate is going to decrease. And as a result, metabolism decreases in the heart. And therefore, you're going to have a little more constriction in the blood vessels in the heart because you don't need as much oxygen and you're not producing as many metabolic byproducts. So the biggest control of the coronary blood flow is local metabolic effects that result from changes in activity within the heart. Now, if you look at the cardiac muscle, we've already talked about previously in earlier lectures about what the cardiac muscle uses for to make ATP. So nutrient-wise, it'll use about anything you give it. It likes to use free fatty acids. It'll use ketone bodies. It'll use glucose. It'll use lactate that you got from, like, if you're working out, the skeletal muscle is producing lactic acid. As long as the cardiac muscle is working aerobically, it can use lactate and convert it into something that can be used for energy. So it's get converted back to pyruvate to acetyl-CoA, goes to the TCA cycle, and you're going to get a bunch of ATP. So it's not very picky. It'll use whatever it needs. And remember, it wants to work aerobically all the time. If the cardiac muscle starts to work anaerobically, it's not getting enough blood flow, not getting enough oxygen, it will start producing lactic acid. And the production of lactic acid locally in the cardiac muscle is going to start shutting down pathways. It denatures enzymes, glycolysis. I mean, when you're producing lactic acid, you produce it from glycolysis. You're getting a little bit of ATP from it, but after a certain point in time, the lactic acid will shut down glycolysis, and you're not going to be able to make ATP. This will lead to cardiac pain. You're going to completely break down the ATP. You'll get adenosine. And here's what can happen. If someone's blood flow is insufficient in the heart and they're all of a sudden having to work anaerobically and they're not being able to open up those vessels to get the metabolic byproducts, so I get that lactic acid away, the complete breakdown of ATP to adenosine, you're like, well, that's a potent vasodilator, but they can't work enough, they still can't get enough oxygen to those tissues because there's some sort, or maybe a blockage within the blood vessel. Adenosine is very soluble. It can be completely lost to the circulation. I mean, if adenosine is phosphorylated, it kind of stays put. But if it's non-phosphorylated, it's lipid soluble and it's lost out to the circulation. Well, if you have ischemia, severe ischemia for more than 30 minutes, it'll cause cell death because of the loss of adenosine. Because you can only make about 2% of your total adenosine needed per hour, and that won't be enough to make the ATP that the cardiac muscle would need to be able to do its thing. So that can lead to muscle death. So that's why it's very important to restore blood flow as quickly as possible if there's any sort of blockage within a coronary blood vessel. So we're going to stop here. So this will be the end of this lecture. In the past, we used to do an entire section on ischemic heart disease, but you'll be covering that in pathology. I just want you to understand that the coronary circulation, it's important to know how it's regulated. The blood flow is regulated in the coronary blood vessels. If you have a general understanding from anatomy of what blood vessels serve what part of the heart, then you can figure out that if I have a blockage in that particular vessel, where am I going to have loss of function or possible cell death within the heart itself.